Okay, welcome everybody. Thank you for joining us on the weekend. I hope you're having a good weekend. If Before I forget, if you have any questions, please use the Q&A at the bottom, and we'll get to them as many of them as we can. So I'd like to introduce Dr. Anil Khan. Dr. Khan is a pediatrician and medical geneticist at the Magic Clinic in Calgary, Alberta, and he's here to talk to us about a new clinical trial and treatment for Pompe disease. Dr. Khan, it's all yours.
Thank you very much, Brad, and thank you to Canadian Pompe Association and all of you for looking at this on your Sunday. And we're going to go through some technical stuff today about this new trial because it's a new technology, and it's being launched first in Canada, actually. And so it's got some new terms: centerin siRNA. Sorry, the I is missing there. Conjugates for the treatment of Pompe disease. And these are my disclosures. The study is through Arrow Biotherapeutics, which I've indicated. I don't know if you can see my cursor, and second page of disclosures. So let's look at this situation with Pompe disease. So the enzyme for Pompe disease is on lysosome, which is on the right. I put that in a parallelogram. And the gene is GAA. The enzyme is acid alpha glucosidase. So it works in the lysosome and it breaks down glycogen, which you'll see in the middle. Brad, can you see my cursor moving? My pointer? No. Okay. So, so glycogen is sugar that builds up in the cells. Some of it you need to have there because if you went on a long walk, for example, or it's a long time from the last meal, in order to support your blood glucose, it has to have a storage form, which is glycogen. The lysosomal glycogen doesn't really affect your blood sugar in that way, but it can cause storage, and it's the main thing that leads to Pompe disease when the lysosomes try to help break down this glycogen, and the enzyme is not working. Glycogen is made by the enzyme on the left, GYS1, well, that's the gene. The enzyme is glycogen synthase. So when you take glucose in, if you drink some sugar, then that sugar has to go somewhere. It will go inside a cell. Glycogen synthase will make the storage form of the sugar because you need a storage form. It can't just sit like that, otherwise your blood sugar would keep going up continuously. So anyhow, so glycogen, there is the storage form of sugar. Yeah, and so the enzyme replacement drugs, those are the enzymes that go into the lysosome. That's where they're going to have an effect. Okay, and the new treatment is going to be on the left side, which is glycogen synthase. So its role is to reduce the amount of glycogen sitting around and make it easier for the lysosomes. So just keep that in mind as we go through the talk today. Now, there's two basic forms of Pompe disease. There's an infantile onset and a later onset. I just used an internet photo on the left to show you the floppiness that we see in infants. On the right is my first patient with Pompe disease, which was an infant who didn't make it. This was before enzyme replacement therapy came out. The pink color that you see is the glycogen, the sugar storage. You can see it's just loading the heart cells all over the place. And then to demonstrate that it is storage, and that's one of the ways to find out if it's Pompe disease, they give it basically an enzyme similar to the enzyme you get for ERT to eat up the glycogen, and then you get the lighter pink staining at the bottom. So you can see that bright pink has been consumed by an enzyme whose only job is to break up glycogen. And in the bottom part, this is just for staining purposes. This patient was not on treatment. The glycogen is less. That's the kind of thing that's being aimed for in this trial, is to reduce the glycogen burden. So, and I thanks, Brad. So for some reason, the pointer doesn't show up, but I've made the slides in a way with arrows already. Hopefully you'll be able to follow. So that's the goal here, is to reduce that glycogen burden. Now, the way the enzyme works is the enzyme ends up in the lysosome to try to eat up this glycogen. This treatment, the centrin siRNA, it's going to be to reduce that amount of glycogen. So late onset Pompe disease is seen with the skeletal features, and the majority of patients in the world have late onset Pompe. So low muscle mass, you can see muscle wasting, facial muscle effects. This is from a journal article. The scapular winging is very common in Pompe disease because you get such significant loss of muscle. So, and then, the standard posture in Pompe disease where it's hard to stand up because there's muscle weakness, and you have to lock your knees, right? And then your head is bent forward to try to keep a center of gravity here to prevent from falling. That's what makes it so difficult to walk. And the standard treatment, rhGAA, which is essentially myozyme, for late onset Pompe disease, the two main outcomes in the studies were to improve 6-minute walk and the breathing, the percent predicted forced vital capacity. In the graphs here, you can see that the 6-minute walk in the study patients is preserved, the forced vital capacity is preserved. But for many patients, they know that their muscle strength deteriorates over time. Inevitably, almost all the patients I've had with late onset Pompe, they're in a wheelchair at some point in their life because they're not able to move. And their breathing can get worse. They go on to CPAP, BiPAP, and sometimes invasive ventilation. So yes, on these charts and graphs, with the patients that were looked at over the time frames looked at, it looks like there's a treatment there, but in reality, there's no cure, and the treatment can slow things down, but there's a lot left not treated. So the enzyme in Canada was approved June 14, 2007. We have to remember a couple of things. When this enzyme infusion goes in, we want it to get to the heart. This is a organ weight sort of relative scale in grams, and we want it to get to the skeletal muscle. But look at the amount of muscle compared to the heart. We know in infantile Pompe disease, the heart thickness tends to respond quite well to enzyme, but the muscle component is a different issue. So that's a key concept here, is it's the biggest organ by weight, and the enzyme needs to get into the muscle. And a lot of it actually does not get into the muscle. That's one of the problems. A lot of it actually goes to the liver. And we'll talk about that as a challenge. So the other thing is, normally your body is making enzyme all the time. So you have some enzyme 24/7. When we give the enzyme infusion, you're going to have lower levels. That's why this bar is lower than here, because you almost have no enzyme at the beginning. And then we give the infusion, it spikes up, but it's usually gone in a day or two, and then the levels are back down. Some of it presumably goes into the cells, but most of the time in between infusions, you're spending without high enzyme levels. And the general thinking is it's better off to try to duplicate the regular situation with drugs that can either keep that enzyme level higher or gene therapy or something of that nature. And well, this is one of the dilemmas with gene therapy. I showed this slide at a previous gene therapy talk, and it's a very busy slide. We're just going to look at two numbers here. I've highlighted muscle at the bottom, and when you compare the amount of muscle versus liver, and when they give the gene therapy, the amount of vector, which is the gene therapy product that goes in there, there's more than 800-fold difference in the amount of vector. 800 times more of it goes to the liver than to the muscle. So getting it into the muscle has always been a challenge with gene therapies, and continues to be. And in this diagram, you see these before and after, 6 months, 5 years after enzyme replacement therapy. You just need to look at the first pink slide. I showed you the pink and the glycogen storage before. You can see 5 years of enzyme replacement therapy in that patient, and you see very little decrease in burden. And that goes throughout all the different stains. And you can see on these brain MRI black and white images, advancement of the disease in the brain too, because the enzyme doesn't cross the blood-brain barrier. And in Calgary, I've had 3 adult patients die since 2006. 1 adult patient is on invasive ventilation. And we've had to stop enzyme because it's doing nothing. And I'm not sure how much it did before we even got there. And I've had 3 infants die just in Calgary. Before I moved to Calgary, I've had infant deaths, at least 2 or 3 other infant deaths before that. So, so we're not in a situation where we really have effective treatment for this. So what are the things that can be done? Well, one of the things is a higher dose of the enzyme. And so in many places now, a higher dose is being considered. So standard dose is 20 milligrams per kilogram every other week. I'm going to move it around a little bit shakiness so that you can see it. And then some people are using up to 40 milligram per kilogram every week. I have a patient who's an infant where we moved up to 40 milligram per kilogram every other week because the heart size was not shrinking. And finally, after years, we actually got shrinkage of the heart size. So, well, that's one of the strategies that's being tried, higher dose enzyme. But it still doesn't reverse things around quite the same, but it may help. Another strategy was to add another molecule, something called a chaperone. A chaperone helps protect the original enzyme that people make from being degraded, which it has a high chance of doing if there's a mutation. And it gives an exogenous ERT, right? So it's a dual therapy. So that has been shown in clinical trials, and we did some patients in that clinical trial here in Calgary. The trial was called Propel, the 2-component therapy. That can help too, but it doesn't work any better than standard enzyme, at least in the trial. But so a lot of thought and effort put into that, but again, we need something that has a little bit more bang. I talked about some of the effects of gene transfer therapy, and most of the gene therapy being developed right now is what we call in vivo, where we inject it. There will be a clinical trial coming up that we will tell you about, where we're looking at antibodies that people make to the gene therapy, which renders it useless in them. And the company wants to just find out what percentage of people make antibodies. It's not a treatment trial yet. And of course, there's the ex vivo, where we take the cells out, we harvest the cells, we put the gene therapy in the cells, put the cells back in. That was being worked at by AVROBio, but I haven't heard that they're working on it anymore. So that's not really out there. I don't know of anybody running the trial in Canada for sure. Another attempt, because remember we said we have to target it into the muscle, is to attach mannose-6-phosphate because there's a receptor in muscle. And that's the basis of the new product from Sanofi, avalglucosidase. And that showed good results in mice, of course, and studies in humans. The COMET trial, for example, used this. And again, the forced vital capacity, 6-minute walk were the 2 outcome measures used. And they found over the time period in the study that they remained stable. I don't believe this had a trial site in Canada. I think some people may have been going to Toronto, but you'll have to double check me on that. So it's gone through Health Canada approval, but it's not on formulary. We can't get it for people. I am managing a patient that was on the trial, and the company is giving the drug, but new people can't get the drug. And this is the one that has the mannose-6-phosphate receptor attached to it. So let's take a look at this genetic stuff again and see another strategy. So DNA is the template from which the instructions are made. Think of it as your bank account. Then you go to the bank machine, you take out $100 because you're going out for the day. That's your RNA, what's in your wallet, the actual instructions from the DNA form. And then that's used to make a protein, which is the enzyme, let's say, for Pompe disease. So gene therapy works at the DNA end, hoping that putting a gene in here will allow it to go through these steps. And of course, that doesn't always happen that straightforward. RNA, which is the source for this treatment, is the instruction to make this, but this RNA is what we call an inhibitory RNA. So it's going to block production of the enzyme that's used to make glycogen. So that's why it's an SI. It's an inhibitory RNA. So normally the enzyme production is coming off the DNA, and this RNA will bind to that RNA and block it. That's what it's trying to do, with the understanding that it makes less of the glycogen synthesis enzyme. So it doesn't affect the Pompe enzyme. It's a different strategy. And again, the issue is you could try that, but it's the receptors that we're going to take up the drug, which are the issue. So these receptors decide what comes in, what stays out. So here's a cell. You want to get the enzyme into the cell. If you're trying to treat with enzyme replacement therapy, you want it to go into the lysosome. And your molecule needs to be able to bind to that receptor. In this particular drug, we don't need it to go to the lysosome. We only need it to go to the cytoplasm of the cell, because that's where the glycogen synthesis occurs. It's not a lysosomal issue. But we need this receptor to make it so that muscle takes most of this up and not liver. And so here come the complicated words. So the way they do it is with this type of molecule, which is called a centrin. So the centrin binds to a receptor on the muscle, which is called the CD71 receptor. So the CD71 will bind the centrin, and that's linked to the RNA. Whoops. And what will happen is the receptor and the centrin bind, and if the elbow is the RNA, it gets swung into the cell. That's how it gets into the cell. And in animal experiments, what they found was there is a higher proportion of uptake into muscle. And that comes in with the thinking of Pompe disease. How are we going to treat Pompe disease? So this is the drug that's in this study. It's centrin siRNA conjugate. Centrin with a linker molecule to an siRNA. This is what gets injected into patients as part of this study. And this siRNA will inhibit glycogen production by inhibiting the enzyme GYS1. And it's gone through different phases. So there were healthy volunteers that were treated. Part A, which is a double-blind placebo-controlled trial. Part B, which is a multi-dose double-blind placebo-controlled trial. So the trial we have starting here is Part C, which is multi-dose open label. So there's no placebo in this. And it would be the first time it's used in late onset Pompe disease. The previous uses were in healthy volunteers. That's just the title of the consent form to give you the verbiage that people might see if they look at the consent form. Phase 1A, 1B, single dose and multi-dose. So these will be multi-dose patients. They just combine the whole thing into one blob. ABX1100-1001. And we're the only site right now in Canada. We're actually the first site in the world to get ethics approval for this. So it presents a unique opportunity for people in Canada to get access to this first line, rather than waiting for everybody else to go through it. This is a scheme of what the study looks like. It's a little complicated. The bars here are representing, I just want to see if there's a message or something. I don't know, something popped up and then went away. Oh, Q&As. Okay, good. Keep coming with the Q&As. Oops, I just don't. Let's go back. Okay, so let's just follow this top part with the green bars, because It represents what's the study scheme, but the font was easier to read. So there's a screening phase, which is up to 28 days. And that would mean coming to Calgary, getting some screening blood work done, and so on. And of course, the trip is covered by the study. And then once you pass screening, people that qualify, and there's detailed qualifying criteria that have to be met, then we proceed on to preparing for the first dose. And prior to the first dose, a first muscle biopsy will be done by me, which is a needle muscle biopsy. I've done hundreds of them, so it's a pretty standard procedure here. And the first dose of the drug is given. Then a second dose is given a little later on, day 30. So you get 2 doses of the drug. And then a second muscle biopsy is done afterwards to see what the effect was on the muscle. So it's not ongoing treatment, it's just 2 doses. That's what the study is about. You don't have to stop your enzyme replacement therapy. You don't have to change the dose. You don't have to change anything else you're doing. This is on top of everything else going on to see what it does. And this is a very detailed schedule of events with the visits. So there's a screening visit, and then you're in Calgary for a little bit. Again, your trip is covered. Day -1 biopsy, right? That's the red bar. And then the next day, a whole bunch of blood work and the treatment dose. So a dose is given as an IV infusion. And then you're here for day 2. If you stick around until day 8, you can do that too, or come back. Physical exam, some blood work, safety monitoring. Day 15, day 28. On day 29, you get another dose. So that's your 2 doses. Then you're monitored day 30, 36, 43. Day 57, you get another muscle biopsy. And then there's just some safety monitoring afterwards that doesn't require a visit. So that's what it looks like. So all told, go back one. There's 57 days until from time 0. Time 0 is going to be treatment, and then a month before that. So 30, 57, so 87 days maximum total involvement. The primary endpoint is safety. It's a safety trial. In the patients, the healthy volunteers that were treated, it did reduce glycogen. That's why it's proceeding forth to this. What it does for Pompe disease patients, we don't know, but it is primarily to look at safety. You get plasma and urine PK measuring, which means there will be multiple blood draws to look to see what the level of the drug is in the blood after we give it, and also in the muscle. And the muscle biopsy is done to look at whether it reduces glycogen content, whether you produce antibodies to it, and a urine hex4 to see if it's chewed up some of those sugar glycogen molecules. Now, the inclusion and exclusion criteria are very detailed. I've summarized them here, but they get very detailed, and there's too many slides to present. But essentially, it's for people 18 to 50 years of age. The body mass index has to fit within these numbers, although there's an amendment to squeeze that out a little bit for regular people. Weight 50 to 90 kilograms, roughly, mostly to make the muscle biopsy doable. And there's some technicalities because they don't want needle-induced other things to happen. Agree not to have body piercing until the end of the study. COVID-19 vaccinations contain mRNA too, so they don't want those 7 days prior and at least until 7 days after the last dose of this. And no live vaccinations. So adults usually don't get live vaccinations. Most of the flu vaccines are not live. Although at the same time, we would say it's probably good when you're in that phase of treatment to get it done before or after. There will be 2 needle muscle biopsies. We do use freezing. I'm not going to say they don't hurt, because they do, but we do use freezing to take the edge off. Of course, they don't want you to get pregnant during this period, so contraception, there's detailed requirements around that. You have to have Pompe disease, documented GAA deficiency, and DNA testing. You can stay on your ERT, but it has to be a stable dose over the last 6 months, so no change in dose over the last 6 months. You have to be able to walk at least 50 meters without an assistive device. your forced vital capacity has to be above or greater than 30%. Most people that are below that will be on some sort of assist. But it's the assist itself is not contraindicated, but the forced vital capacity is one of the criteria. So like I said, these are general criteria. There's more detailed criteria that we can go over if you're interested and you want to talk about it. Exclusion criteria, no other muscle biopsy in the last 3 months. This is undergoing an amendment 2 because the biopsy, you have 2 legs, and I can always biopsy the other leg if for whatever reason you're having it biopsied. You can't be on another study though. So that's one of the key issues. And that's to avoid confusion with outcomes. No other major significant health issue, no cancer within the last 5 years. QT intervals, your heart rate measurement on an ECG, no major surgery last 6 months that would interfere with the study, like a broken leg, for example. They don't want you smoking for at least 6 months prior to getting into the study, negative for hepatitis or HIV, negative for any drugs of abuse. Medicated stuff is okay, including cannabinoids, as long as there's a prescription for it or you're using it as a treatment purpose. No systemic steroids, because of course they can cause muscle issues and rhabdomyolysis in some patients. Not participating in another trial. And these get very nitty gritty and we can go over these in detail. But basically, you just have the Pompe disease, nothing else going on, is how they're looking at it. What are some of the adverse events in those healthy subjects that were treated? Well, they all showed knockdown of GYS1 with a repeat biopsy at 29 days after a single dose. Keep in mind here, there are 2 doses. They had high CK. It didn't get super high, but I think the biggest value I read was about just over 1,000, which for CK things is not that high. A lot of Pompe patients may be running about half that. Of course, procedural pain because there's a biopsy, and sometimes aberrant pain responses. There was one reported insulin hypersensitivity reaction. I don't know if that was drug related, but you have to report these things, and then they have to be evaluated medically. And there was an infusion-related reaction. So those of you that have been on infusions know what infusion-related reactions are. It didn't lead to stoppage of the drug or anything like that. So those are the type of things that people have experienced before. There've been no deaths or other major things like that happen. Now, this is a registry we launched. If you want to get more information about this, you can scan this QR code with your phone. I'll show it up again in the question and answer period. It's called Viper, for verified interest to participate in research. And we can send out information to you. And if new Pompe studies start, we can send out information to you just as a way to get Canadians access to this information in a more disciplined form. And with that, I'll end there. And the QR code is up and you can ask any questions. So one of the questions, would this drug be compatible with Amicus drug as well as with Myozyme? So the Amicus drug does not have approval in Canada. If you're on the drug as part of a study, then we can't do 2 studies at once. So that's what it'll come down to. So right now, I would say it's not clear what the interaction with that would be. Of course, we don't want to go into your personal details on this chat, but you could let me know. If you search Magic Clinic Calgary, you will find an email link there, and Magic, and then you can email us. That'll be the website. But I would say, because that's not an approved therapy in Canada, it would still be considered that you're on an extension phase or compassionate phase of an experimental drug if you're on the Amicus drug. Does binding affect other components or just glycogen? As far as we can tell, just glycogen. At this stage of the study, it's hard to know all those things in detail. Do you know when it's supposed to begin? So recruitment has actually started, and we are booking patients for screening before the end of the year. I think we've got 2 patients coming in. So we thought we'd get the word out to people. I think if you, other than those 2 patients, if you want to be screened, we'll probably be setting up dates now, I guess in January, to do the screening. But it kind of depends how far you are and how hard it is to get here. So if it's easy to get here, then screening doesn't involve the muscle biopsy. It's just blood work and other stuff, 6-minute walk, so on. Then it may be possible to do a screening if you're eligible before the end of the year, but it's probably going to be in January. Now, other questions?
Hi, Dr. Khan. We had a few questions that were submitted beforehand.
Sure.
One of them was you've already addressed, actually. There was one, is there any concern that we might reduce the glycogen too much? And if that was to happen, how would we know?
Well, and I asked the same question to the company. If we reduce the glycogen too much, we might expect to see hypoglycemia. But that's if it got into the liver too. And it doesn't seem to get into the liver very much. So, and they haven't seen hypoglycemia. In muscle, what you might see is you might have possibly increased fatigue or decreased stamina because that glycogen would be used up. At the doses they're using up until now, that hasn't been the case. But of course, in a trial like this, it's hard to say for sure that's going to be the case. So that's probably the best thing I can say about it right now. Is if you look at the total muscle mass and the total dose of any product like this, I don't know that there's that much of a dose that it would have that type of effect, but that'll have to be wait to be seen. Okay, so other questions? You had a second one there,
yeah. Yeah, I have a couple. This was somebody that lives in Eastern Canada.
Yeah.
And they're just wondering if all the assessments need to be done in Calgary, or could some be done locally?
They have to be done in Calgary. It's the nature of the way research trials are conducted. When a research trial is conducted, we have an inspection from an outside body, and we're registered with ethics for everything that we do here. And if a center is not registered that way and inspected, then they're not allowed to even do a blood draw for the trial. So we'd be happy to talk to you, of course, because we want all Canadians to have access to this. But yeah, you'd have to come here for those assessments. But they would be on those days that are specified.
Okay, and I have one question myself. Is there any flexibility in the age requirement if the patient was to satisfy all the other requirements?
Well, right now, the short answer is no, because they set these strict requirements and then the safety boards look to see whether everybody in that window, they did okay, and then the stretching of the boundaries occurs later. So if you're, let's say, 17 and change, for example, we can't stretch it right now. But it is, my guess is if things are positive and they move forward, then, well, if you're 17, you'll turn 18 by then. And, or they may bring the age range down, because typically in many of the studies, adolescents often are squeezed in first before kids. The upper age range you would think is even more flexible. And I think, you know, it's at a stage of the trial where, of course, amendments happen very quickly. And if all of a sudden 3 people showed up that were 60, then we'd have to say to the company, what do you want to do about this? And then they'd seek approvals through Health Canada and ethics. That's hard to do ahead of time unless we know what the patient population is. So if there is an interest, then do contact me, because then I can go back to the company and say, hey, look, I don't know why you guys set the top age at 50, because there's 3 people that are above 50 and they're interested, and then we can look at to see what to do about it. So, is a question that says, is a trial for Canadians only? Uh, right now, yes, because in Canada, we have more of a universal healthcare plan. So if you ran into an infection and you went to a different part of Canada, your home city, or if you got sick in Alberta, and unless if you're from Quebec, then your healthcare is covered. Your antibiotics are covered. Your hospital admission is covered. All that is covered. If you're coming from outside the country, then you'd have to have coverage in case you ended up in a clinical hospital with a complication. So that's a little more complicated. Depending now, Germany, you don't need a visa to come from Germany. In some countries, there's a visa requirement, and we expect the study to, at some point, if things are positive, to get launched in other countries as well. But right now, because of some of those issues, it's mostly Canadians that we're looking to screen, unless you're an expatriate and you have Canada Health coverage and you just happen to be living in another country and you come back for this, because then your health coverage would cover you. I think that answers one of the anonymous questions too about US patients. And we talked to the company. At some point, they hope to have a trial site in the US. I think right now, because it's just so early in this, and because of that issue of complications and the need for local health care as a backup, it's and ethics requirements and Health Canada requirements right now. It's for Canadian recruitment primarily.
Could you talk just for a little bit about the muscle biopsy?
Sure.
I just had a needle biopsy,
Yeah.
and previously I had the open one, and
Oh,
it's much different. So just to make sure that everybody understands.
Sure. And so there's a question about Quebec candidates. Quebec candidates are accepted. The issue with Quebec candidates is there's no reciprocity agreement for healthcare. Doesn't affect the research study, but if you got sick here and needed healthcare, because the provinces don't have an exchange agreement with Quebec, then you have to pay for your healthcare cash, go back home, and then try to get it from the Quebec government. That's going to be a bit of a challenge, because the Quebec government's going to say, why'd you go to Alberta? Well, I went there for a study, and they're going to say, well, that's not our problem. And you could be stuck with a big bill in case something happens. So you may need to get travel insurance or something like that to come here. And we've said that to the company. We're in negotiations with the company. If you do happen to have insurance, then I don't see it as being an obstacle. You're more than welcome to come and participate in the study. That's not an obstacle. It's in case you get sick from something else. And then, Brad, your question, needle muscle biopsy. So I've done needle muscle biopsies all my life. I was trained by Dr. Tarnopolsky, who's done many more. I'd say the majority of people, because I end up doing patients who have had open biopsies too, but didn't have a specific workup done and didn't get a diagnosis and needed repeat biopsy. Most of the patients have tolerated the needle biopsies better. I've done them in babies as small as 34 weeks, premature babies gestation, and in older people upwards of 85 years of age. And so not every center does them. I'm not sure where you had yours done. You don't have to tell me, but there may be a few other people in the country that do them, but I think Mark and I do most of them.
Yeah, Mark did mine.
Okay.
It was such a different experience.
Yeah.
I personally wouldn't hesitate to do it again, but I know that's not everybody's experience.
Of course. Yeah.
Yeah.
Other questions? No,
I guess not.
no other questions. That's an introduction. I gave you the website. You can contact us by email. Oh, we may have one more pop in. Ian, how are you doing, Ian? How long would it take to be available to patients on a ventilator and bound to a wheelchair? I don't know. I think these things work their way through slowly, and I just don't know, Ian. And but of course, if you're signed up for Viper and new versions come out, we would email you to let you know if that changed. And I think some of it is just the phase of where the study is at. In order to get a drug through the system, you have to show, first non-affected people and then a specific group of affected people as you continue to expand the boundaries of who gets included. Okay.
Okay.
Oh, one more popped up. Okay, you're welcome. Oh, is there an open extension if the first two doses go well? There isn't one set up right now, but one would presume that once the safety board looks at this and the regulatory authorities look at this, their idea behind this technology is you get the IV injection, let's say every 3 to 4 months, to sort of renew the dosing rather than every 2 weeks. And the hope is at some point that's the type of trial that would come out. And hopefully the people that were in this trial don't get excluded from that. The product does not stay in your body permanently. So it's not a gene therapy. It's actually out of your bloodstream very quickly in a day or two. And then it's taken up by the muscle, and those instructions, kind of like the vaccine, you need to get revaccinated every year. So the effect of the drug is supposed to last a few months, but then wear off. Okay, well, thank you all very much.
Yeah.
Okay, thank
Thank
you.
you for doing this for us.
No worries. Bye-bye.